Welcome to Learn with Livanta, a new podcast focused on Medicare beneficiaries and their rights to high-quality care under the Medicare program. My name is Lisa Novak, and I am the Associate Vice President of Strategic Communications at Livanta, and I am thrilled to be kicking off our inaugural episode. Today's episode celebrates Livanta's 10-year anniversary as a beneficiary and family-centered care quality improvement organization, or what we typically call a BFCC-QIO. As a Medicare BFCC-QIO, Livanta conducts medical record reviews when a Medicare patient has concerns about the quality of the health care they are receiving. Future episodes of our podcast will include discussions on topics that are critical to Medicare patients and their families, including subjects like patient safety, discharge planning, health equity, health literacy, the medical record review process, and other elements of our work in supporting Medicare patients. At this time, I'll turn the program over to our host, Noah Shapiro.
Welcome to Learn with Livanta, Medicare, the BFCC-QIO, and you, Livanta's podcast where we bring you up-to-date information about Livanta's services for Medicare beneficiaries and the overall Medicare and healthcare landscape. I'm your host, Noah Shapiro, a communications specialist here at Livanta. In this month's episodes, we are recognizing the 10-year anniversary of the BFCC-QIO program by bringing you conversations with Lance Coss, the Executive Director of Livanta's QIO program, and Dr. Matthew Stofferahn, our Chief Medical Officer.
My name is Matthew Stofferahn. I am a physician. Specifically, I'm board certified in emergency medicine and internal medicine, and I am the medical director for the QIO program. My role is I am the medical director of the BFCC QIO program, and what that essentially means is I'm basically like the chief clinical officer for the QIO. And so I really oversee anything that has to do with the medical aspects of what we do, the clinical aspects of what we do. I think the most forefront of that is overseeing the physician reviewers. So we have a panel of about 170 or so physician reviewers, and a lot of our activities as the QIO really involve physician review of particular cases. And so my role as the medical director is really to make sure that those physician reviewers are educated about our processes, that they are trained appropriately, that they're doing the reviews in a high quality manner. Really just to make sure that our beneficiaries are getting the most out of the review, not only in terms of making sure that they're receiving quality care, but also getting the care that they're entitled to under the Medicare program. And in addition to that, as the medical director, I'm sort of the provider and government-facing person when it comes to medical issues that the QIO might be facing. So for instance, I'll interface a lot of the times with CMS, with Medicare Advantage plans, with advocacy organizations, if they have questions about our activities, if they have concerns about what we're doing and have medical questions about what we're doing, then I'll often answer those and be sort of that person facing those organizations. I'm also happy to participate in some of the focused reviews that CMS asks for. In other words, part of the QIO's responsibility is to analyze current trends in the care that Medicare beneficiaries are receiving, certain problems that are coming up, hot topics, so to speak. And if any of those deserve sort of a deeper dive using the QIO's case review processes, then I help suggest those and interface with CMS with regards to those. And then finally, this is a good example of what I do as well, in that with communications, if there's medical content in our publications, with the podcast, then I often participate and edit those as well.
It seems like you've got a real strong passion for the work that we do here at Livanta. Could you tell me, where does that personal passion for the BFCC QIO work come from for you?
Yeah, so when I finished medical school and my residency training, and I started working in the community as a physician in the emergency department and in hospitals, I began to become increasingly interested in the drivers of various outcomes that my patients were experiencing, other than just the care that I was personally providing to them. I could examine them, I could counsel them, I could write prescriptions and those kinds of things. But often patients were still suffering setbacks in their conditions. They were being readmitted to the hospital. And I was starting to recognize that a lot of those drivers were really outside of my control, both in terms of, for instance, if they were uninsured or underinsured, they weren't able to access prescriptions or get help that they needed. If there were certain social determinants of health that affected them, such as not having transportation to get to doctor's appointments, they would often end up back in the emergency department or in the hospital, really because of things that were more system related rather than what we would traditionally think of as care that healthcare providers give. And so I became increasingly interested in really improving the quality of care that people received, not just from my perspective, but from a more global perspective as well, taking into account our healthcare system, governmental aspects, social aspects, and that kind of thing. And with quality of care, it became pretty clear that it was a really complicated problem, and that sort of interested me. And that wasn't something that I had a lot of experience in through medical school training. And I started looking more into that. And I really realized that improving quality of care is a goal that, although complicated and difficult, is something that everyone can get behind. Everybody is a stakeholder in that. Certainly patients in terms of improving their conditions and relieving suffering, but also physicians want to see their patients do well. Hospitals want to have their patients do well. Even insurance companies want patients to do really well so that they don't have downstream effects, which increases the cost of care and everything like that. So it really struck me as a universal goal, and that really jived with my motivations and my intrinsic motivations as a physician to alleviate suffering and provide good health care. And I was introduced by a friend to the QIO program, and it immediately struck me, it's in the name, Quality Improvement Organization, the QIO, and it really served as a central role. As a Medicare contractor, there's a really defined mission, which really appealed to me, and that we were taking individual beneficiaries, specifically protecting their rights, making sure that they receive quality care, making sure that they receive the care that they are entitled to. And that really appealed to me. It wasn't about, utilization, which is important, but often there's sort of a financial motivation. With the QIO, it seemed like that was out of the picture, and it was more consistent with my mission as a physician and the Hippocratic Oath, which is to directly interface with beneficiaries and ensure they're getting proper care. And there are a lot of organizations out there that are really concentrated on that, and like the Joint Commission and those kinds of things. But I always found, as a practicing physician, when my care came under scrutiny or was questioned by peer reviewers or those kinds of things, it almost seemed maybe not punitive, but sort of a one-sided process. And when I started working with the QIO, I really realized that our role is very collaborative. So except in very rare circumstances, our process isn't punitive at all. We reach out with our sister organizations, the Quality Innovation Networks, to really improve the quality of care in a collaborative manner, and not impose penalties and not impose fines, but rather just work with providers and say, hey, a beneficiary reached out to us about this concern that they had. We found through our review process that they were right. And I think there's an opportunity here to improve your processes of care and to improve that, not just for Medicare beneficiaries, but for all patients. And I think providers really respond positively to that collaborative manner. And so that really appealed to me as well. And so at that point, I sort of realized that the QIO is where I wanted to be in order to solve these problems.
Part of what we're doing here at the QIO is working to improve healthcare outcomes all across the board. Could you tell me a little bit more about why it's so important to be so forward thinking in having, cutting edge medical expertise at the forefront of what we do here at the QIO?
Yeah, absolutely. So that's another thing that really appealed to me about the QIO, is that our processes specifically call for physician reviewers who are actively practicing, who are board certified, which requires that they maintain their certification, and that requires ongoing medical education to make sure that all of our physicians are up to date. They also have to work in the same regions as the providers that we're scrutinizing as well. And that's really, really important because healthcare is incredibly complicated. And that's speaking just not only about the system itself, but also about the medical science that underlies the care that we give. And it's so difficult to even just stay up to date with that. Yet Medicare beneficiaries really need to receive the highest quality of care possible. They deserve that, and that's our goal, is to foster that. And so in order to make sure that the quality improvement organization is truly making sure that the highest quality of care is being provided to our beneficiaries, we need those up-to-date medical experts in order to analyze that care, in order to really opine about whether that's occurring or not. And, just thinking back to my own practice when I was in the community, and of course I still am actually as a part-time emergency physician, but when there were QI efforts, quality improvement efforts aimed at, improving care on a hospital level or a state level or a national level, a lot of those efforts really rely on abstraction, coding, metrics, and really at the base of that is looking in medical records for things like check boxes. Did the physician check this box to say why they did this action? And unfortunately, that really kind of makes a very gray science, which is medicine, sort of separates it out into black and white. And I found that that process really doesn't take into account a lot of the nuances, a lot of the new high end up-to-date information that we really need to take into account when we're scrutinizing care. And that's really frustrating. And I think it's frustrating for a lot of providers. The COVID pandemic was a really great example of that because the science was changing on a month-to-month basis. And what was the standard of care in August wasn't the standard of care in October. And there's no amount of coding or abstraction or algorithms that you can put into a quality improvement effort to really accurately say whether the standard of care is being given. But if you're using a board certified physician who's actively practicing in a COVID environment, they know what is the standard of care in August and they know what is the standard of care in October, and they can look at a record and make that distinction. And so that doesn't penalize a provider for not checking a specific box. And it also ensures that our Medicare beneficiaries truly are getting the standard of care and the most up-to-date care. And so when our physician reviewers look at a record, they're really considering all of the context. They're making their own judgment, using their own expertise. And as a result, I like to think that our quality reviews and our appeal reviews are more accurate and individualized to that specific beneficiary and their specific situation. And that's really not something that you're going to find a lot of the time in the quality improvement realm. And so I'm really proud to say that that's our process.
You talked a lot there about some of the specifics about really that high level, what we do here at Livanta as the BFCC-QIO. I'd like to take a minute to kind of zoom down a little bit. What are the actual services that Livanta provides for Medicare beneficiaries?
Yeah, there's actually a lot that we do. I think the most common review that we do and what most people probably know that we do are what are called appeal reviews. And these are reviews that involve our board certified physician reviewers where we look at particular levels of care. So hospitals, skilled nursing facilities, home health services, hospice services. And when a decision is made by the provider or insurance company to terminate those services, or in the case of a hospital appeal, if the attending physician decides to discharge the beneficiary, our beneficiaries have a right to ask us to basically double check that decision. And we use the medical record that's provided to us by the provider to scrutinize that care and really make sure that the decision to discharge a patient from a hospital, the decision to terminate home health or hospice services, the decision to terminate coverage for skilled nursing facility services is correct. And we use prevailing standards of care to do that. We use criteria that are set out in the policy manuals for Medicare. And it's a really nice service that we provide to really ensure, again, really to serve as a double check to make sure that our beneficiaries are getting the care that they are entitled to. And so I think that's what most people are familiar with. But there's a lot of other services that we do in terms of if beneficiaries have concerns about their care that they're getting immediately. For instance, if they're calling their doctor's office and aren't receiving a response, or they know that they don't need to be in the hospital, but yet they have concerns about leaving the hospital, we do have an immediate advocacy service that doesn't involve our physicians, but we do have board certified patient advocates as well as nurses that can answer questions. They can support beneficiaries by intervening on their behalf, for instance, reaching out to doctors' offices, reaching out to the case manager at the hospital to say that a beneficiary has questions. And often those problems can be solved really at the point of care through better communication. And that's been a very, very successful program that we really try to use whenever it's applicable and whenever we think that it will avoid, either a complaint down the road or, God forbid, additional morbidity or a bounce back to the hospital for that beneficiary. And so that's something that people may not be aware that we offer, but is something that we do try to maximize as much as possible. And so I would encourage people to use those services. And then we also do chart reviews when there's a concern about the quality of care that's being provided. And unlike the advocacy services and the appeal services, those are retrospective, which means that it takes place after the care was already given. But if a beneficiary has concern about a recent hospitalization or a concern about what a physician did, we'll scrutinize that medical record and determine whether the standard of care was given. And if it wasn't, that's when we really bring in that collaboration that I was speaking about, where we'll reach out to the provider. We'll leverage our sister organizations, the Quality Innovation Network, QIOs, to work with that provider to recognize problems, to drill down on the root causes of that problem, to develop a plan to fix them. And really, that's so that future patients do not experience those problems. And we're really looking for systemic issues that we can fix through better processes. That's really the foundation of quality improvement. And it's a really nice collaborative process to make sure that our beneficiaries who are signaling the alarm about a possible problem, that alarm goes back into our processes to eventually result in fixing the problem. So it's a really beneficiary-centered process, and that's a nice thing that we can offer. We also have important missions in terms of not just ensuring that quality of care is intact and provided to our beneficiaries and that they receive the care that they're entitled to, but we also have another mission, which is to protect the Medicare Trust Fund and to make sure that unnecessary care is not paid for, and to make sure that governmental and taxpayer dollars are not being used in a way that doesn't benefit patients and beneficiaries. And so we do screen every case when we do an appeal review, when we do a quality of care review. We screen those for medically unnecessary care. And if we find that, we do interface with other organizations to recoup those costs. And then also we do have a claim review service. And to speak in sort of a high level manner about those services, we're really just making sure that hospitals, when they are billing for services that they provide, are doing so in a correct manner and not overbilling for services that they're providing. And so we do that as a nationwide contract as well. So we sort of have a two-pronged approach. We definitely support beneficiaries and their families in terms of making sure that they get appropriate care and timely care. And then we also make sure that Medicare's trust fund is being used in a responsible manner.
You've really guided us through sort of the high level overview of the services that Livanta provides and how we interface with beneficiaries. And I know you don't always get the opportunity to speak directly to the beneficiaries that we get to work with. So if you could, in a sort of soapbox way, speak directly to Medicare beneficiaries and their caregivers, what would you tell them about Livanta and the QIO services?
Yeah, the main thing I would want to do is really just increase awareness. And I hope that this podcast will help us do that. Medicare is a critically important program, and it really covers those people in our population in the United States that in general need more healthcare and are interfacing with healthcare system more than other parts of the population. And so it's really important that those beneficiaries of Medicare know what benefits they have and how to access them before they need them, because certainly all of us need to interface with the healthcare system at one point or another. And so that includes not just knowing about the services that the QIO offers, but also knowing what benefits they get from Medicare versus a Medicare Advantage plan. And importantly, what they don't necessarily get. Obviously, traditional Medicare doesn't cover some services like dental services, vision services, hearing services, long-term care. And it's really important that we help people understand those types of things before they need them, so that they're not caught off guard and that there's not a gap in care, and hopefully not any adverse ramifications of not receiving care when they need it. And so the message really would be that help in doing that is always available. Medicare has, of course, the 1-800-Medicare hotline, the Medicare.gov website. There's state SHIPs, which are the state health insurance assistance programs that are really specifically there to answer people's questions about Medicare, help them select policies that they might need based on their individual situations. They can lay out options. And I would encourage everyone who's eligible for Medicare and signing up for Medicare to know that that help is available. And of course, that Livanta is available. Again, with our immediate advocacy services, we can intervene on your behalf if there's a question. And importantly, even if there's a problem that a Medicare beneficiary is having that we don't necessarily have a tool to address directly, we can point them in the right direction. Ultimately, our mission is to help Medicare beneficiaries, and I want people to take advantage of us. We are a free service for Medicare beneficiaries and their families, and we want nothing more than for people to call us and let us help.
On the communications team, we get to actually very regularly interface with the SHIPs, the SMPs, and other regional Medicare-based organizations. And what we really consistently hear from them is just equally as we're here to help, they are too, and they're on the ground in their communities and have really great relationships with their Medicare beneficiary communities. So it's, we really work in tandem with all of the local organizations in the regions that we service. Well, Dr. Matt, I want to thank you both for your time and expertise. We are all in this work together, supporting Medicare beneficiaries and the Medicare Trust Fund. And before you go, I just want to give you one last opportunity if you kind of feel like there's anything else that you wanted to put out there in the QIO universe.
Yeah, just to say that the QIO is here to improve quality and to advocate for beneficiaries and to support our healthcare system to maximize the good that we can do for our citizens and Medicare beneficiaries. And so please reach out. If there's ever any question, we'll find a way to help.
My name's Lance Coss. I'm the Senior Vice President, and I also hold the role of Executive Director of the Quality Improvement Organization here at Livanta. I've been in the QIO world for 27 years now.
Can you give us a general description of what a BFCC-QIO is and what role we play in the Medicare world?
BFCC-QIO stands for Beneficiary and Family-Centered Care Quality Improvement Organization. It's one of the largest federal programs in existence for improving the health care quality for Medicare beneficiaries. It's an integral part of the U.S. Department of Health and Human Services National Quality Strategy for improving better care and better health at lower costs. By law, the QIO program is designed to do four things. It's to improve the effectiveness, the efficiency, the economy, and the quality of services delivered to Medicare beneficiaries. As a BFCC QIO, CMS identifies several core functions for the BFCC QIOs. The first of that is obviously improving the quality of care for Medicare beneficiaries. We also protect the integrity of the Medicare Trust Fund by ensuring that Medicare pays only for goods and services that are reasonable, necessary, and are provided in the most appropriate setting. And we also protect our Medicare beneficiaries. We do that through things like investigating quality of care complaints that are initiated by the beneficiary, other general quality of care concerns that are identified from other parties within the federal program. We also do the very important emergency medical and treatment and active labor law, aka EMTALA reviews, and several other administrative tests and other administrative functions for the Medicare program.
This month, we're celebrating the 10th anniversary of the creation of specifically the BFCC-QIO program. Can you just guide us through a little bit of that history of how this program came to be exactly what it is today?
Yeah, I can't believe it's been 10 years. So you got to go all the way back to in 1971 is when Congress first authorized the development of what were called MCROs, because CMS likes their acronyms. And an MCRO was an experimental medical care review organization. And it was the first one really designed to evaluate the services that are being provided to Medicare beneficiaries. That was in existence for a year, and it appeared to be working. So then President Richard Nixon in 1972 signed into existence what were known as Professional Standards Review Organizations, or PSROs. They were formed they were the first federally funded physician review organizations. And they were to ensure that both Medicare and Medicaid beneficiaries received what the government felt was medically necessary care. They were in existence for 10 years. And then in 1982, the PSROs became PROs, which were known as the Medicare Utilization and Quality Control Review Organizations. The pros pretty much had the same mission of improving the effectiveness, efficiency, economy, and quality of care that I've talked about, but that was also the first time that they added the prospective payment system with what we now know as DRGs, or diagnosis-related groups. That was the big change in 1982, when we became known as pros. Pros were in existence all the way up until 2002, when CMS rebranded us as quality improvement organizations to get away from the sole focus on peer review. We were in existence for 12 years. And then in 2014 is when CMS really looked hard at the program and thought there was a collaborative side of the program and a more quality assurance side of the program. And maybe the same provider or the same quality improvement organization that was trying to work collaboratively with providers to improve care shouldn't be the same ones coming behind them and evaluating that care. So in 2014, CMS actually divided the programs. I should also state, up until 2014, we were always state-based organizations. So there was 53 different QIOs that covered every state and territory in the country. And in 2014, CMS really made a big change. Not only did we separate into BFCC, Beneficiary and Family Centered Quality Quality Improvement Organizations, but also QIN, Quality Innovative Network Quality Improvement Organizations. But we went from being state-based organizations to large regional-based organizations. So 2014 is really where we saw the most movement in decades with CMS and the program. And as we stand today, we hold 2 of the contracts that do the clinical oversight portion of the contract. For CMS, we have half the country, and our friends Accenture have the other half of the country. And then we also hold the national contract to do the billing and coding reviews for CMS that are really looking at, protecting the Medicare Trust Fund.
Since 2014, the entire landscape of the world has changed. The technology innovations, healthcare innovations, and just, overall the world has changed quite a lot in the last 10 years. So, from where we stand now in 2024, looking back, what have you personally seen as sort of the biggest improvements and innovations here in Livanta as we support our work as the BFCC-QIO?
Besides the sheer growth of the program, which has been astronomical and above all previous projections, we like to think of ourselves, and CMS actually calls us the technology QIO. We like to, throw technology to help us in all of our daily systems and our daily processes. Anywhere we can, we're trying to support our staff with the use of, systems. And if you look ahead, I think the next 5 years, maybe 7 years, are going to be earth-shattering in what we're able to do. I think 10 years from now, it's not going to look anything like it does today.
We've been talking on a pretty high level about the work here at Livanta, the BFCC-QIO, and the overall landscape. If you had the opportunity to personally say something to Medicare beneficiaries, their advocates, what would you say to them about the work that we do here at Livanta?
Use us. We're here. We're a free service. Our work with CMS has exploded over the last 10 years, but still only a fraction of the Medicare patients that need us use us. So we like to spend a lot of our time just getting the message out there that we're here, this is what we do, and this is what we can help you with.
We hope you learned something new about the QIO program and Livanta services by listening in to our podcast today. You can learn even more by visiting our website, levantaQIO.cms.gov, or following us on social media. We are at Livanta Cares, CARES, on X, Instagram, Facebook, and LinkedIn. Tune in next month for even more incredible conversations surrounding Medicare, the BFCC-QIO, and you. Thanks for listening to Learn with Livanta.